I'm happy to be here this afternoon. I'm Keita Franklin. I'm a social worker by trade, so I'm not a medical doctor like Captain Colston. I came up over the years doing installation-based mental health and program administration through the military branches and at the service headquarters and at the DoD and now at the VA. Just as a military child and spouse also. So I'm quite happy to be here to be sharing this information with all of you. And what I've brought is some sort of state of the program in the context of the VA and what some of our approaches are, as well as some tools and capabilities that we're learning about and that we're using. You may have heard before this figure about 20 veterans a day that end their life by suicide. Whenever we talk about veteran suicide, we always try to talk about it in the context of the larger problem, the national problem. And we very quickly shift, and it's no surprise to anybody in this room that there are 123 people that end their life per day, of which 20 are veterans. And within the 20, I'm not sure everybody always knows that we include our active duty numbers in there. So 1 to 2 per day are from the active duty side of the house. The other piece that we've been educating people on that really helps frame our strategy, so I want to spend a minute on it, is the fact that when we pull the thread on the 20 veterans that end their life per day, we see 6 of them have touched our healthcare system. Those of you that may know the VA well know that it's we have a healthcare system, we have a benefits-based system, and we have a cemetery system, and all of that collectively makes up the VA. Well, 6 of the 20 touch the VA healthcare system in the days and months leading up to their death by suicide. 14 do not. And so if you think about our strategy and you think about all that we know that is true in the context of providing hospital-based, medical-based suicide prevention work, you would very quickly come to the realization that even with our best work, with our best gold standard methods and all things hospital-based, evidence-based, treatment, therapies, medication across the board, we might chip away and do better at the 6 that touch our system. If you step aside from the suicide content for a minute and just think VA-wide and veteran-wide, we have a slide, I don't think I have it with me, but there's 20 million veterans in the world. There's 20 million veterans. About half of them get health care from the VA and about half don't. It's like 7.9 and 10.2, or it's something like that. So half and half. And so that just sort of gives you a universal look of who gets health care where and all of that. To help frame this discussion of the 14 and the 6 is just this notion that we've got to really work outside our system. We're not just trying to prevent we're not trying to prevent veteran suicide with those who come to our healthcare system. That's not our charge. Our charge is to prevent veteran suicide amongst a whole 20 million population. And so it's a little bit speaks to how we have to have strategies inside, outside, and all around coordinated well in order to get after the problem. We talk a lot about veterans who are at risk, and you can go through this list yourself. I'll probably just highlight on a few. When you look at our data, and I want to talk about men over the age of 50 because I know that's an ongoing phenomenon for my civilian counterparts in the room, like Richard McEwen and many of you that I recognize that could be up here giving this brief as well. We have certainly a problem with veterans over the age of 50. We also have more of them. As the cohort of the veteran movement go through the lifespan, we have more of them. But when we run our analysis by rate, we have our highest rate is 18 to 34-year-olds. And so then that quickly sweeps around to this work that you heard Captain Colston, I think, talk about people in periods of transition, and this idea that there may be a period of transition right after a service member leaves the military. The military has taken great strides with their transition assistance program to prepare veterans for career readiness, they call it, like career readiness standards. They even have these terms, like make sure they know how to dress for success and they know how to interview properly and they have a job when they leave. When questions remain about whether or not they know how to adjust to the social aspects of no longer wearing the uniform. What might it be like for a 20 or 30-year colonel to enter a room and no longer have that uniform on when perhaps they don't carry the social status and standing, or maybe they've fallen from glory, and maybe what they have to share isn't as important as it used to be yesterday when they were in uniform. And I say this a little bit jokingly, knowing that, it's happened right in my own family. So I just tell you, periods of transition are rocky. We have zoned in on the first year after after leaving DoD or leaving the military, I should say, as a period of risk. And we're continuing to study what year 2 looks like, year 3, 4, and 5, and that will be something to bring to this committee in the out years. In part, I just took a data brief on it yesterday, and I think that there's going to be more to be said about tracking the trajectory of veteran suicide death in terms of the recency of which they've left the military. I think folks in this room know well risk and protective factors, but know that our model stands on the premise of improving protective factors and reducing risk in all that we do. So quite simply. And I shared about the 14 and the 6 to tell you that we are moving beyond a hospital-based model where we wait for people to come to us to a broad, comprehensive public health approach. And we are looking at evidence in the social sciences, in the social work literature, and maybe in the adult learning and the education literature, and in some cases the science, and looking at methods that have worked with things like seatbelts and other sorts of public health strategies like HIV prevention and things like that. And we're trying to draw where we can, in the context of do no harm, we're trying to draw public health activities and actions that are measurable and build a more robust evidence base for broad public health strategies, many of which are on this sort of grid here that you can dig into, and I'm happy to talk more about with anybody. We have adopted the National Academies of Science Prevention Continuum, also that you heard Captain Colston talk about, and these are some examples of interventions that we're doing in this context. Part of why I highlight it for you is because it sweeps back to this notion of doing broad-based universal work. And so I give you some simple examples like making sure that every community provider or chaplain or peer, not necessarily peer because they would know that somebody was a veteran, but making sure people know to ask the question, are you a veteran and have you ever served? Because then that opens the door to getting them into the right care channels and improving their access to care and really working left of a potential crisis. So we are also pushing inside the VA that there's no wrong door for care. So I don't want you to think the takeaway is that we're trying to singularly identify those at risk and just bring them into our system alone, because we're not. Like, we're thinking if they're at risk, we want them to get care where they want to get care. Of course, the best care possible. And there was a recent RAND study that spoke to the fact that when we get them into VA care, we know that they do better than their non-VA care cohort counterparts, if that makes sense. So getting them in actually puts them on a trajectory for goodness and health and all things wellness in life. But equally so, if we can get them into some sort of system of care that's good in quality and meets the standards of all things you would expect for your own family member for care is what's important. So just know that back to that slide where the grid is, we're moving out with a broad public-based public health strategy whereby we've taken the National Academies, the nation's suicide prevention strategy, and we have adopted it for our VA system. And we have recently, just in the past 2 months, pushed out, I want to show you the cover, what it looks like. We've pushed out this national strategy for preventing veteran suicide. Carefully titled, in part, it's not VA's strategy. It's definitely not VHA's strategy, right? This is the national strategy for preventing veteran suicide. And it maps onto the same set of strategic directions, a similar set of goals and actions, but through the lens of veteran care and through the lens of what resources we have available to us for veterans. And it calls for this notion of meeting veterans where they live and thrive. Like, we will come to you and we will bring capabilities to bear to you and for you through everyday actions of life. And all that goes with a complex integrated system when you do that. It's not going to be easily evaluated, but it is possible. So that's what we're doing with this strategy. It's a 10-year plan. So recognizing that it won't happen overnight and it'll continue to get updated on a regular basis. So that gives you a little bit about sort of the once around on the program: broad public health, all universal selected indicated, not just hospital-based, all 20 million. 2014-6, give you some of the takeaways, and sort of we have a number of actions across all of those. I do want to make sure you know that we're also working with predictive analytic modeling. Those of you that have maybe heard of ReachVet, how many of you? Oh, many. Okay, I'm not going to go into too much of details. Know that we just got the first set of 6 months of data back from ReachVet, and we did an all-cause mortality analysis, meaning like the dependent variable was life or death, not just suicide. And those that we identified risks in the predictive algorithm in the context of a help-seeking population, that we got into ReachVet and did caring outreach and calls and got them back into a care system, fared better and had an increased propensity for life than death. And so that's the first set of 6 months worth of analysis, and the next round, which would give us a whole 12 months, is in process and due here within end of October. So that is the status of ReachVet. We are, I think Captain Colson talked about the good, the bad, and the ugly of DoD VA clinical practice guidelines and how hard this work is, and the fact that we're doing it together. And then I just brought some resources. We have a mental health and suicide prevention guidebook that guides a lot of our work. In part, it's something that VACO puts out at the national level to try to put us all on the same standard of care across all the VA system, with it being such a large hospital-based system. I shared that we're trying to work with various lines of effort: first responders, people in the finance industry, legal attorneys. These are gatekeepers that we believe touch our people when they might be at risk. And so we're giving them, like, this is an example of one, but a toolkit, and we're giving them information so that they can be force multipliers and help us in this fight against suicide. You see also that we have this suicide risk management consultation program. This is the goodness of this model is any clinical provider that's ever serving a veteran that's just stuck. They're stuck in their treatment. They're stuck in delivering the therapy. They're unsure about CBT in a PTSD environment with wartime trauma, and they can call and get consultation and sort of work through, how to do some of that work. We have rolled out also our first standardized training called SAVE in collaboration with PsychArmor, a nonprofit that partners with us. This is a 25-minute long training that it's your basic 101 class that people can take online. What I've been offering to people, it gives gold nuggets on who's at risk, why they're at risk. It's very interactive, so it's not your sort of death by PowerPoint, but the best way to take it is to take it and then do like a debriefing with your team afterwards, so that you talk through what people learned and see if it impacted them, and just sort of don't just have people taking it in isolation, is what we're telling people at their desk by themselves. Bit of an update on VCL and MCL. After plussing up the VCL, so it started in Canandaigua, New York. We have one in Atlanta. We built one up in Kansas, and they have all these metrics and how many seconds the calls are coming in and how quickly they're being answered, and all things improving and doing quite well. They're getting about 2,000 calls a day, and they're making 60 to 70 saves a day, whereby they're dispatching. They have this operational definition of what a save is, and so they're doing some extraordinary work. Also trying to leverage peer support in doing that, and thinking through the way ahead in this space. Also working, trying to improve our capabilities where we have veterans posting risks online, like on social media. They'll go to these public domain websites, Vet for Vet on a Facebook site, and they'll list my life is awful, I feel very isolated and lonely, and I'm thinking of ending it. And so us having a proactive approach in finding those people where they're at and getting them the resources that they need as part of a add-on to the VCL is a little bit of the way forward with that capability, so that we're not just waiting for people to call us. In fact, we're scanning and we're going to them and helping them solve problems. If they're having a problem with the pharmacy in Kansas, well, we got you. If they're also feeling lonely, well, let's make sure that they're connected to somebody, and just some of that work, which is necessary and I think new, taking it to them. So that's what I have, and I'm eager to participate in the Q&A. Thank you, ma'am.